Hello again and welcome back. In this video, I will present a head-to-head surgical comparison between the Ahmed Glaucoma Valve and the Paul Glaucoma Implant, highlighting how differences in implant choice are accompanied by differences in tube location, quadrant selection, scleral tunnel design, and flow control strategy. Let us start with the first case. This is a Paul Glaucoma Implant case in an adult patient with refractory glaucoma with a history of failed GAT and trabeculectomy. Given the previous surgeries, this was a complex secondary tube procedure. In this case, the implant was placed in the superotemporal quadrant. The tube was inserted into the anterior chamber and a two-step scleral tunnel technique was used. A Ripcord strategy was also applied to allow safer early postoperative flow control. This case demonstrates the key surgical principles of PGI implantation. At this stage, the superotemporal conjunctiva and Tennant's capsule are carefully dissected using Westcott scissors until the bare scleral surface is fully exposed. This step provides adequate surgical access and allows proper preparation of the implantation site. During creation of the pocket for the plate in the superotemporal quadrant, it is important to switch from Westcott scissors to Stevens scissors. Because of the larger profile of the Paul Glaucoma implant plate, Stevens scissors allow a broader and more suitable posterior pocket to be fashioned, ensuring that the implant sits comfortably and without undue tissue tension. 280 Vicryl traction sutures are then passed through the peripheral cornea. The advantage of using two sutures is that the traction force is shared between two different entry points rather than being focused on a single area. This provides more balanced globe rotation, better surgical exposure, and more stable control during posterior dissection and plate positioning. Here, standard dose mitomycin C is applied using sponge pieces that have been stained with trypan blue, and the exposure is maintained for 3 minutes. I find trypan blue particularly useful because it makes the sponges much easier to identify during removal and helps prevent them from being missed within the orbital tissues. This is followed by thorough irrigation with at least 20 cubic centimeters of balanced salt solution to clear any remaining MMC from the surgical site. At this point, the plate is secured with 6 0-proline fixation sutures, passed approximately 12 mm posterior to the limbus. I intentionally choose this distance to position the plate more posteriorly, with the aim of directing aqueous outflow not only toward the conventional blood reservoir but also toward the posterior intraconal space. In my view, this posterior placement may help create a broader drainage pathway and potentially improve posterior flow distribution. After priming the tube, I advance a 6-0 proline ripcord suture along the full length of the lumen. This is a critical step for protection against early postoperative hypotony. Based on my personal experience, leaving the ripcord throughout the entire lumen provides the most reliable and consistent early flow control. The 6-0 proline fixation suture is then passed through the plate holes in a horizontal mattress fashion. Before tying the suture, I use a muscle hook to gently elevate the superior rectus and first position one edge of the plate beneath it. I then lift the lateral rectus and guide the opposite edge of the plate under that muscle as well. This maneuver is very important for long-term implant stability. If the plate is simply pushed directly into the prepared pocket without proper placement beneath the rectus muscles, the risk of postoperative implant extrusion or explantation increases significantly. I tie the horizontal mattress fixation suture in a way that leaves the knot buried beneath the plate. I prefer this configuration because it helps reduce the risk of postoperative suture erosion. I also use proline rather than Vicryl for plate fixation, as my goal is to achieve better long-term implant stability and to minimize the chance of later plate movement, including movement related to eye rubbing or external mechanical forces. Another reason I prefer the horizontal mattress configuration is that it brings the plate into broad and firm apposition with the globe, allowing the implant to conform more closely to the scleral surface. At this stage, I apply cautery with the lowest effective energy while maintaining continuous irrigation. My goal is to obtain adequate hemostasis while avoiding unnecessary thermal injury to the sclera and surrounding tissues. At this stage, I create limbus parallel scleral incisions with a number 15 blade. These cuts will serve as the starting points for constructing the scleral tunnel and the scleral flap. This scleral flap differs from the flaps used in trabeculectomy or deep sclerectomy in several important ways. First, it is fashioned at approximately 80% scleral thickness. I consider this thickness important to provide adequate long-term coverage over the tube and to reduce the risk of post-operative scleral erosion. Second, the flap is not extended all the way to the limbus. Instead, it is stopped about 2 millimeters posterior to the limbus, leaving this anterior segment intact for subsequent tunnel creation with a 26-gauge insulin needle. The main purpose of this flap is to cover the tube, thereby helping to prevent early post-operative peritubular leakage and reducing the risk of late tube erosion. At this stage, a two-step scleral tunnel is created with a crescent blade, again at approximately 80% scleral depth. 2 points are particularly critical here. First, the globe should not be overly tense because excessive scleral resistance may cause unintended deepening of the dissection and increase the risk of entering the suprachoroidal space. Second, once the crescent blade reaches the intended depth at the start of the tunnel, it should then be advanced parallel to the natural curvature of the globe. In my experience, these two principles are the key to avoiding inadvertent suprachoroidal penetration during tunnel creation. Afterward, the thin tube is advanced beneath the scleral tunnels and brought into the flap area. The tube remains at approximately 80% scleral depth beneath the tunnels, and it is also maintained at the same 80% depth under the scleral flap. From this uniform plane, it is then directed into the anterior chamber in a course parallel to the iris. Maintaining the tube at the same depth throughout its entire path is very important because it prevents bending or kinking of the tube along the scleral surface. In the post-operative period, this helps reduce mechanical stress during eyelid movements and serves as one of the most important protective factors against erosion of the overlying sclera. When it is time to enter the anterior chamber, the first priority is to bring the globe into a true coaxial position so that the entry is made in a proper horizontal plane. At this stage, the traction suture can be removed. A paracentesis is then created and a small amount of viscoelastic is injected into the anterior chamber to maintain chamber stability after tube entry and to reduce the risk of lens touch. However, the most important point is to estimate the intended anterior chamber entry level before injecting the viscoelastic. Once the OVD is injected, the iris is pushed posteriorly. If the entry site is then judged only by centering between the cornea and the displaced iris, there is a real risk of entering too posteriorly and injuring the iris root. This can lead to post-operative resistant hyphema, and in a hypotenuse eye, controlling hyphema can be particularly difficult. When preparing the tube tip, I prefer a bevel-up cut for anterior chamber insertion and a bevel-down cut for sulcus placement. One important technical tip at this stage is that the more oblique the bevel is, the sharper the tube tip becomes and the easier it enters the eye. A well-fashioned, sharper bevel allows smoother tissue penetration and gives better control during insertion. In addition, bimanual two-point grasping of the tube improves control during advancement. The scleral flap is then secured to the recipient bed with two 10-0 nylon sutures. At this stage, I prefer to take a shorter bite from the flap and a longer bite from the recipient bed. This improves wound edge apposition and also makes it easier to bury the sutures. Once the flap is closed, the thin tube remains completely within the intrascleral space. I consider this a protective approach as it helps reduce the risks of tube erosion, peritubular leakage, and post-operative endophthalmitis. The external end of the ripcord suture is then passed through the sclera using a Z-suture technique. The suture is cut at the scleral exit point, and a small loop is left near the limbus. This configuration serves two important purposes. First, it prevents the proline end from eroding through the conjunctiva, and second, if intraocular pressure rises later in the postoperative period, the ripcord can be easily removed by simply grasping this limbal loop. At the end of the case, once the 10-0 nylon sutures are carefully buried, the conjunctiva and Tennant's capsule are then closed. Then, intracameral antibiotic is administered, and the paracentesis is sealed by stromal hydration. The viscoelastic that was placed earlier in the anterior chamber does not need to be completely removed. To be clear, the anterior chamber should not be overfilled with OVD. However, leaving a small to moderate amount behind can be beneficial, as it helps prevent an abrupt pressure drop and promotes a more gradual early postoperative IOP reduction. In my view, this may also help reduce the risk of choroidal complications. I now move to case 2, an Ahmed glaucoma valve implantation in an adult patient with traumatic glaucoma. This eye had a particularly challenging surgical history, including penetrating eye trauma, complicated cataract surgery, and 2 failed trabeculectomies. In addition, because there was superior scleral damage, I preferred inferonasal implantation. The tube was placed in the sulcus using a single-step scleral tunnel approach. Here, the inferonasal conjunctiva and tenon are dissected to expose the bare scleral surface. The inferonasal bed is then prepared with Westcott scissors. Because the Ahmed plate is relatively small, further widening with Stevens scissors is generally not necessary. Similar to the previous Paul implant case, standard dose mitomycin C is applied using sponge pieces with a 3-minute exposure time and is followed by thorough irrigation with balanced salt solution. Here again, I fix the Ahmed Glaucoma Valve plate 12 mm posterior to the limbus using a 6-0 Prolene horizontal mattress suture. I prefer this more posterior fixation in order to encourage aqueous outflow not only into the conventional periplate reservoir but also toward the posterior orbital space. I also favor Prolene over Vicryl for its greater long-term stability, helping to minimize later plate movement. In addition, the horizontal mattress configuration provides broader apposition of the plate to the globe, allowing the implant to conform more closely to the scleral surface. I tie the knot beneath the plate, which also helps reduce the risk of postoperative suture erosion. While handling the Ahmed glaucoma valve at this step, I make sure not to grasp the valve body directly. Protecting the valve mechanism is important because any inadvertent damage may affect its proper function. As in the previous case, cautery is performed with the lowest effective energy under continuous irrigation to achieve hemostasis while limiting thermal injury. Keeping the sclera well hydrated at this stage is essential. Since the sclera contains a high water content, drying causes it to thin excessively and develop a blue color. In that condition, controlled dissection for flap or tunnel creation becomes extremely difficult. Similar to the previous case, limbus parallel scleral incisions are first created with a number 15 blade. However, unlike the previous Paul implant case, here a single long scleral tunnel of approximately 6 to 7 mm is created. The AGV tube is then engaged with fine tying forceps by inserting one tip into the tube lumen, allowing the tube to be securely grasped and guided through the scleral tunnel in a controlled fashion. At this stage, the scleral flap is fashioned in a manner similar to the previous case. Using the limbus parallel scleral incisions as the starting lines, I dissect a partial thickness flap at approximately 80% scleral depth. As in the first case, this thickness is intentional. It provides sufficiently robust coverage over the tube, helping to reduce the risk of postoperative erosion of the overlying sclera. The flap is not extended all the way to the limbus. Instead, it is stopped about 2 mm posterior to the limbus, leaving the most anterior portion intact for controlled tube entry. The main purpose of this flap is to cover the tube along its anterior course, thereby helping to prevent early peritubular leakage and offering long-term protection against late tube exposure. For sulcus insertion, the tube is trimmed bevel down to reduce the risk of iris tissue obstructing the lumen. I also leave it slightly longer than I would for anterior chamber placement since endothelial trauma is not the primary concern in the sulcus. In contrast to the PGI case, the entry tract here is created with a 23-gauge needle rather than a 26-gauge needle, better matching the dimensions of the Ahmed tube. The bevel angle is also important. A more oblique cut produces a sharper tip, facilitating smoother and more controlled sulcus entry. Finally, two-instrument manipulation improves tube control and helps guide the tip more precisely into the sulcus plane. The scleral flap is then closed in a manner similar to the previous case. Here, however, I use 3 10-0 nylon sutures instead of 2, adding an extra suture at the flap apex to ensure complete closure and more secure coverage over the tube. My goal at this stage is to achieve a watertight and stable flap closure. Unlike the PGI case, a Ripcord suture is not required here because the Ahmed device already contains a valve mechanism. However, special care must be taken while priming the tube in order to protect that valve. I prefer to prime the tube gently, avoiding excessive pressure, and if possible I use a 1 cc insulin syringe for more controlled irrigation. This is important because if the valve is damaged during priming, early postoperative hypotony becomes almost inevitable. After burying the nylon sutures, we can see that the thin tube remains completely covered beneath the sclera. As in the previous case, the conjunctiva and Tennant's capsule are then closed over the implant. Keeping the tube entirely intrascleral provides additional protection against tube erosion, peritubular leakage, and postoperative infection. Finally, here you can appreciate the appearance of the tube in the sulcus at postoperative month 1. The tube is positioned bevel down, aligned at the level of the pupil, and remains completely covered by the sclera. Thank you very much for your patience and for watching this video. I hope this comparison has served as a useful practical guide for surgeons with an interest in glaucoma drainage device surgery.